This is Tea with Dr. D. So it's the second Tea with Dr. D, and I've been very interested in having our particular guest for a Tea with Dr. D because I think the video aspect is going to bring a lot to life, and that's Dr. Karan Lal. So Karan, it's great to have you here this morning to toast with you to the second D with Dr. D program. Okay.
Cheers.
Thanks for being here. Cheers. And you're drinking coffee, correct?
Coffee, yep.
Yep. So we are into inclusivity, whether it's tea or coffee. We're happy that you're joining us. So Dr. Karan Lal, who I'm happy to say is a friend as well as a colleague, is in private practice at Affiliated Dermatology in Phoenix, Arizona for the last 3 years. He has a breadth of experience in a relatively short period of time, having been trained in dermatology and board certified in dermatology, pediatric dermatology, where he's also board certified, and completed a cosmetic dermatology fellowship with Dr. David Goldberg in New Jersey. So he covers from the beginning to right before the end, helping people with their dermatology conditions and also with cosmetic concerns. So it's great to have you here.
Thanks for having me.
So tell me, you are director of the pediatric dermatology portion of the Omni residency program in Arizona, correct?
Yep.
So in your spare time between 3 and 5 in the morning, you tend to get some of these things done, right?
Yes, exactly.
So I had spoken to you a few months back about why I wanted you on Tea with Dr. D. Tea with Dr. D is our video component of the Derms and Conditions podcast platform. And so the reason why is because I look at your posts and I see some excellent photographs. It's very interesting, the photographic system that you used to show the progression before, often during, but certainly at the end of taking a patient through the treatment of medical dermatology conditions, pediatrics, adolescents, adults, and also cosmetics. So you had 4 cases, and there were many others, but 4 that cover a spectrum of a lot of different things that we face in dermatology, and you handled all 4 of these. So let's talk about the first case. I believe you had a case of bullous pemphigoid that actually was drug-associated or drug-induced. So can you walk us through this case? Because I was fascinated not only by what actually happened, but what you actually did in managing this case.
So, this gentleman came to me because he had metastatic melanoma that was not even in his skin. So they couldn't find a primary. He was on immunotherapy and did very well with the immunotherapy. Essentially became no evidence of disease. During the process, developed these, erosive plaques on the head and neck. And he had a biopsy done by an outside provider. He was diagnosed with bullous pemphigoid. They obviously started him on prednisone. He's older. He's in his mid to late 80s. Very functioning, very with it, still very active. And it just wasn't budging. And so they had done dupilumab at that time, which is now currently FDA approved. That really didn't work. He then was started on IVIG, which was helping a little bit. And then he was kind of stuck. And so
let me ask you a question, though. He had been on systemic corticosteroids, but certainly they didn't want to use them on an everyday basis. They want to get it under control, but it comes back. You can't keep it under control. How did he do when he was actually on the corticosteroids?
I think because it was so short, they didn't notice that much of a difference, and they didn't want that to be a primary mode of therapy because of the immunotherapy. And there's some controversy when they treat people with these, immunotherapy drugs because in one aspect, you're, boosting the immune system. And on the other aspect, if you get an adverse event that requires systemic therapy, you're reducing the immune system. And so are you decreasing the efficacy of these immunotherapy drugs? And so that's kind of why, they decided they would try it for short term and then they'd figure out what to do next. And I don't even think that portion was done by a dermatologist. I think that was by oncology. So they did their best.
So I remember when you presented this case, and we'll be looking at the actual photographs of the case very soon, which I appreciate you bringing those. And I appreciate that you get the patient's consent to be able to use these photographs in any medium for education, which is So helpful. Uh, this patient had what was determined to be potentially associated with the therapy that they had and not a primary bullous pemphigoid. So I think it
Hmm.
would be interesting to discuss how that actually affects the testing that you might do for the diagnosis and also how you manage the case. So can we go on to the details of the case? That'd be helpful.
Yeah. And so, when we look at this guy, and the interesting thing is his presentation to me did not appear to be like bullous pemphigoid when I first met him. It's not a classic bullous pemphigoid scenario. And the interesting thing I've learned after doing some research about these cases is they often do present these atypical presentations.
So
So these,
what was atypical about it?
I mean, for me, head and neck location, no active bullae, like very minimal actual peripheral disease. I feel like most of my bullous pemphigoid patients, they have the classic either urticarial plaques that are very itchy, or they have these large bullae that are tense. He didn't really have that many symptoms either.
So he didn't have the pruritus. He didn't have that urticarial appearing phase. It more was on the head and neck rather
Yep.
than truncal and extremities.
Yes.
But it was erosive, so if there were any bully, they were gone.
They were gone. Yeah.
They had already eroded down. So what made you think of bullous pemphigoid?
I kind of was anchored in this position because he came in and he had a biopsy done on the outside. So they had done a punch biopsy, they had done a DIF to get that diagnosis. He was seeing another dermatologist at the time. And so, when I saw this case, I was thinking, is it more of a cicatricial pemphigoid? Because it looked like there was some scarring. And, that's a little bit more classic on the head and neck. He didn't have any ocular involvement, oral involvement. So I was just trying to think outside the box. Um, and it was hard for me to believe that he had big bullae on his scalp, but apparently there are these cicatricial-like pemphigoid presentations that are actually bullous pemphigoid. So,
Let's look at the case
yeah.
and walk through it if we could bring up the slide. So what are we seeing in this particular case, and how did you determine what the causative agent was?
Yep. So if you look at the scalp, you see these widespread, well demarcated, big erosive plaque. Interestingly, very minimal discomfort, very minimal pain. Because some people would look at that border and say, "Oh, could it be pyoderma gangrenosum?" I entertained all of these things. Of course, I was anchored because I already came in with some pathologic evidence. And on the scalp, it looked like, could this be a potentially cutaneous coccidiomycosis? We live in Arizona. He was immunosuppressed. Like, what else could this be? Those are the things that I was thinking out. And so I had to make sure, on the biopsy report, and I spoke to the pathologist, that was the actual result.
So you don't assume because somebody told you they had a diagnosis, you don't assume that diagnosis is correct. You have to go backwards and make sure you're comfortable with the diagnosis. So you're going to pick the wrong treatment or not, or maybe a deleterious treatment. So
Yeah.
what agent was this associated with?
I believe this was on PDL1 therapy. So he
Okay.
was on a pretty good treatment routine for his, and he did very well. Outside of this, had no other real adverse events, which is pretty interesting again.
So, from reading the literature, and I actually had reviewed this a little while back, even before the recent approval of dupilumab for bullous pemphigoid, that the gliptin agents are, based on all the case reports that people have collectively looked at, are the number one agents involved with inducing bullous pemphigoid. But the PDL1s are either second or third on that list. So, it's pretty likely that we may run into this type of situation. So, how did you determine that it wasn't something else?
Yeah, I mean, I think we were kind of lucky in the sense that this guy's otherwise healthy, is not really on any other medications, and so that was pretty easy to make that connection. It happened relatively quickly after being on immunotherapy, and it just continued to evolve. So I think timing wise, we were lucky. There was no polypharmacy involved, so that's how they probably came up with that diagnosis, and that was my connection to the drug that he was on.
So, this is a challenge because you have someone that has metastatic disease. They're responding to their PDL1 therapy, but now they're having a significant complication from it. So, Dr. Lal, that's why they called you in on the case. So, what did you do?
So I said, you know what? IVIG is amazing. And I was like, it's not going to hurt having IVIG at 80 years old. Like if you're someone that's already potentially immunosuppressed, or, your immune system is dysfunctional, IVIG has good adjunctive data for bullous pemphigoid. It's not really first line. And so I said, that's not, and if insurance was covering it, I said, why not? What becomes complicated is, I wanted to do dupilumab, but he had already failed dupilumab and he had done a fair trial. So I said, you know what, let's try what's next. What could be next? So, I started him on some topical clobetasol because regardless, those plaques needed some topical treatment. He wasn't really treating them from a wound care perspective. And then I did some work and I was like, you know what, I feel like there could be a role for JAK inhibitors here.
So that's interesting because, jacks have a big noise level because of the box warnings, and we understand the realities of that. But the problem is that makes people think, oh, this guy has a cancer. We could never utilize a Janus kinase inhibitor therapy, which is not true. It's a warning.
Yep.
But thinking through it, that was something that I'm sitting here with metastatic disease. I'm 80 years old. That this disease can kill me. This therapy is working for me.
Yep.
Why would I not consider utilizing something that may be a risk, but often is not if you actually look at the literature. So how did you embark on this? Did you get any pushback from any of the other clinicians?
So, I always get permission, right? Because I'm his second provider. His first provider is his oncologist. That's who he's going to listen to. And luckily I knew the oncologist, had a good relationship with the oncologist. I got some papers, I made my explanation, built a case that there's some data to show that Janus kinase inhibitors pretty quickly can help reduce antibodies, and assist with decreasing inflammation in this pathway. And his oncologist said, well, he already has cancer, so what's the, what are we doing? What's the risk here? Otherwise, very healthy. The other concern is IVIG. IVIG can also increase your risk of blood clots. So my concern was more for a blood clot than it was cancer.
Interesting.
Because I'm like, he's older, in his 80s, on IVIG, and he's taking a pretty hefty dose of IVIG, pretty often. He was doing it once a week at that time. So that was my concern. Oncology was not concerned at all. And in fact, they use these drugs in many patients that have other types of cancers. So they were like, sure, if you want to try it, go ahead. We'll just monitor. And
so let me ask you a question with the antibodies. In these drug-induced cases, do you see the same response with the serologies, the antibodies that we test for, in terms of forming related to the drug-induced disease and going down with the response to treatment, or is it going to be different?
No, I mean, his antibodies went down, so we had pretty good evidence to say that the drug did, in fact, help. I mean, he was on a lot of things, but really it was that JAK inhibitor that really made that picture happen, because up until then, he was stable. Even on IVIG, there was no improvement. And so he did have a reduction in his antibodies.
So you treated him with the Janus kinase inhibitor. Which one? How did you dose it? And what was the course of his response?
Yeah, we did upadacitinib 15 milligrams a day, which is the lowest dose, because he's over 65, and he had been on that. And you can see that picture was just after, I believe, 6 to 8 weeks. And so it was pretty easy. He was getting labs done anyway, and I felt like this was going to be the right option. I didn't think we need to go any higher, and he did well on 15 milligrams. We were even able to get him off, so now he's off the drug.
Did he stay on the PDL1 agent while he was on the upadacitinib, obviously?
And he had finished his course, so he's done with that for now.
Okay, good. So how far out is he now from
probably 4 months.
Well, great. So he's staying on his upadacitinib. He stayed on the 15 milligram. He did not need an updose to the 30 milligram.
Once he cleared up, we were able to get him off the drug. So he's right now at least off upadacitinib, and he has no active lesions.
Fantastic. And if the bullous pemphigoid comes back, you would restart him on the upadacitinib?
Absolutely.
Fantastic. But the reason why I found this so fascinating and wanted you to discuss this case, because I think a lot of clinicians, because of that knee-jerk reflex fear of his history of cancer, would not think it through to take that step. So I have to tip my hat to you on that. So what's our next crazy Karan case?
Yeah. Our next case is actually a really good case, something that resonates with me a lot because I love treating teenagers, early adults. I think that's a really fun age. And so this guy came to see me, very good looking guy, college student, and was losing a lot of hair. And, he had seen another provider that had given him topical steroids, and had diagnosed him with didn't even give him a good diagnosis. He didn't really know. He said he was told he had hair loss. So he comes to see me, and if you look in the picture on the left, he has a lot of that central thinning, a lot of scalp show. And my biggest question was, does he have alopecia areata? Because I did a hair pull test. Hair was coming out a lot, way more than 25% of the amount of hairs I was pulling. Or does he
So
have?
let me stop there and ask you a question because we read do a hair pull test.
Mhm.
So we're not talking about yanking hard, you know, very lightly pulling and the hair easily comes out. So
Yeah.
how do you actually decide where you're going to do the pull from and how you do the test? Because we assume, like we tell people who do a KOH, but nobody ever showed you how to do it,
Yeah.
right? So this is another example of that. So how do you do the hair pull?
So I typically will do it in two places. I'll do it in the center area. So I did it in the center where he had that active hair loss, and at the periphery. And I usually will grab about like 50 hairs. And that's an easy number for me to remember, like what looks like half, what looks like a quarter. And you're just, like I said, yeah, you're not yanking. This is not like when we have loose anagen syndrome where we actually have to yank. This is just, it's really pulling to see how much inflammation is in the scalp that's causing that hair to easily pop out. So
Right.
it's not a force, because if you pull your hair, you're going to get hair. So
Right.
it's really needs to be a, you know,
And you have to tell them, I'm not going to yank on your hair. I'm just lightly pulling so that, because even younger patients or any patient is going to be afraid that it's going to hurt, right?
yeah,
Okay. So the hair pull test was an easy positive. So that
easy
made
positive.
you think
Yeah, and then I
uh,
was down this pathway. Are we in inflammation, or is this non-inflammatory? And I said, at this point, I think before I make a decision on therapy, it's not classic, it's not clear cut. Let's do some biopsies. So we did two 4 millimeter punches, one for horizontal sectioning, one for vertical sectioning. So
where did you take the biopsies from? That's
I
another
took
thing
them.
people
Yep,
don't.
I took the biopsies from the center of the scalp where the active hair loss was.
So do
Um,
you include a few areas of hair or where it's totally devoid of hair?
Kind of both. I mean, he was lucky where he pretty much still had follicular ostia and he had hairs present. So, I mean, I tried to go in an area where I'm going to get some hair loss because I want that to be noticeable. I want to see what is the reduction in follicles.
Right.
And so I did it in that area where it was kind of mixed, but also hidden enough that it's not going to be obvious.
Okay. And you did two of them, right?
Two,
Two
yep,
biopsies.
two
Okay.
biopsies, which is pretty standard for hair. If you're going to do it, you need to do two, and you need a label, one for vertical sectioning, which tells you, the level of inflammation, but also looks at scarring. And then horizontal sectioning tells you, the catagen to telogen ratio, the depth of inflammation. So it's giving you different information. And luckily, he only had male pattern baldness. He had no inflammation. And so this is an easy, let's start him on minoxidil and finasteride. And 3 months later, he comes back, and that's what his hair looks like. He got so much hair
So
back.
interesting. Okay. Finasteride and low dose minoxidil, oral minoxidil. You're not
Oral
talking about
minoxidil.
topical. You're talking about oral minoxidil, which I happen to be on. That's another story for another day. But um, uh, and had been on finasteride, ran into
Hmm.
some difficulties. But we're not here to talk about me. But it's just I'm paying attention.
Yeah.
But you use the combination together. So why did you choose both of them together versus one or the other?
I trained with a doctor who always told me that time is hair. And it's when it comes to hair, you're better off doing the most that you can first and always taper because you want to see what type of response you're going to get. And so this was a young kid, 19, 20, college kid. He wasn't bullied by it, but culturally there's a lot of concerns. I remember when I was losing my hair, my parents were all over me. So I said, you know what, we're just going to do both. You're young. The risk of adverse events is low in young patients. He had no background sexual dysfunction. And, that's my biggest concern. And I don't really put people on dutasteride right away. That's more of if you don't respond to finasteride or you're losing a response, that's when we switch.
So
And
let's stop there. And the difference between finasteride and dutasteride as to why one versus the other.
Theoretically, the data shows that dutasteride is more effective because it's a more potent DHT blocker, and it has more specificity for the scalp. However, it has a very long half-life, so if someone does have a sexual adverse event, it could take weeks for them to recover, and that I think would give me more anxiety as someone that's prescribing the medication. So it's
Okay.
much higher risk in a younger age patient.
Okay, so you're starting with the finasteride at the 1 milligram a day dose, correct?
Correct. Yep.
All right. And what about the low dose oral minoxidil? But being a male versus what they recommend in females,
We
uh,
started, yeah. We started
what
at
dose?
2.5 milligrams. So we started at one pill a day. I try to keep it easy. And he did very well. Very, very
Right.
well.
So some of the things they talk about with oral minoxidil, the hypotensive effect, I think the literature shows it's negligible. Obviously, if someone was much older and already had orthostatic hypertension, you still think about things like that, but you're really not concerned about precipitous drops in blood pressure. But sometimes you can get ankle swelling or even eyelid swelling. How often have you seen that?
I have right now probably two patients. One patient, he's a male. He gets facial swelling but loves his response, so he stays on it. I have another patient who's an elderly female that has leg swelling. Hers was kind of dramatic and made me panic a little bit. But so for her, we stopped the therapy and we went to topical therapy. And we made sure we rule out a DVT. We did the whole workup, but the swelling is weird and it's
It,
unpredictable.
and it's pretty uncommon in my
Yeah.
experience, but you do need to be aware of it and be able to address it. So now you started both of the therapies together, and I think your explanation of being sure of the diagnosis is important because you don't want to be treating for alopecia areata, especially with a systemic therapy when the patient has androgenetic alopecia. So that explanation was excellent. But now you have them on both. Are you going to continue them on both once you notice a response? But let me ask you first, how long does it take to truly assess to be able to appreciate a response? Because it's not going to change overnight.
Yeah, it won't change overnight. I mean, for him, he younger guy, he made the changes. We saw an improvement in 3 months. Most people, I will say, I will 4 to 6 months, and I won't even consider it a failure unless it's been a year. So I
Okay.
give people a year. That's pretty standard, I think, amongst hair experts. Same thing with the JAK inhibitors for alopecia areata. I think we give it a year before we kind
Right.
of say it's time to move on. You know?
Right. They have to be ready to see time changes. So one of the things I learned, having been on finasteride for almost 20 years and switching to low dose minoxidil, 2.5 milligram a day, and then eventually going up to BID, was with minoxidil, you do get periodic increases in hair shedding, almost like a telogen effluvium effect, more than you get with finasteride. So you have to warn people about that because they're going to be thinking it's not working when it really is,
Mm-hmm.
right? So have you seen that?
Yes. I mean, and that's the biggest challenge with a lot of hair conditions is for some odd reason, before they start growing hair, there is a shedding phase, whether it's topical, whether it's oral, and that is where I think you can lose a patient if you're not seeing them back soon enough to counsel them, to make them
Right,
realize like this is normal, don't panic.
right, and to know that up front, but they
Mhm.
can certainly call if they're they're still afraid of what's actually happening. So now they're on both. At what point do you decide to have them switch to only one agent, and which one do you go with?
I think because I think of this more ethnically because I've been through this as well. So, Indian, Middle Eastern, Mediterranean, we know that there's higher testosterone sensitivity in the scalp. So, for these patients, ideally, I'd like to keep them on both. If I have to, I probably would take off the minoxidil first and leave them on finasteride because I think in terms of retention of hair, treating it from the hormonal aspect, which is the primary cause, is my biggest thing. I think of minoxidil as a fertilizer. But if he's okay with taking both of them, I'm going to be okay with having him on it long term. I'm not worried about it.
Right. So one of the things that I learned somewhat the hard way with a patient is patients have to recognize what can happen with their testing for prostate cancer, with the blood
Hmm.
test that we do for prostate cancer, and how that can be affected by the finasteride and get false elevations. So,
Hmm.
can you explain that scenario?
Yeah, so there is, so it used to be that a lot of people check, and I remember before I started finasteride, they asked I had to get a PSA done to get your baseline. I don't really do that anymore because when I talk to my urology colleagues, they don't know what to do with the information because they can't use their new value as a good marker because there is a false elevation. So I
Right.
think that space is kind of controversial. Even digital rectal exams now for prostate cancer are not even like a thing. So there are false elevations, but the data still shows that people that are on finasteride um, have a lower risk of prostate cancer. Although
Yes.
if they get it, it's a higher grade.
Right.
So
Because it's kind of slid under the radar, right?
exactly.
Right. It's slid under the radar. So one of the things, even if you're not testing it, I think it would be important to tell a patient because they may get that by somebody else and they're not aware it's a false elevation. Make sure if you go to a primary care doctor or move or go somewhere else that you let them know because if they do PSA testing, it can influence the result. So
Yep.
I had one case where patient went through all kinds of testing and it was all a false elevation and
hmm
they weren't adequately informed. So this patient's doing well. How far out are they
They're
now?
probably now out 5 months, but we had a beautiful response at 3 months, which, it's a hit or miss. Some people respond really quickly, some people take a little bit longer. I think we caught him in a very active phase where he was actively going through, his prime of the androgenetic alopecia. And I remember when I was going through that phase, and I think because we acted early, we had a better response.
So, Karan, being someone that spent a lot of his career paying attention to rosacea, you had a very interesting case of a patient with rhinophyma, which is certainly not new to those of us that are in dermatology, and how you managed it. But you also had another interesting caveat in there where you educated regarding utilizing oral isotretinoin. So I think that's something that people know is out there, but they don't think about it. They forget that you have the opportunity to use oral isotretinoin for certain situations in rosacea, and certainly the development of rhinophyma
hmm
when it's more soft sebaceous and not fibrotic. So do you mind if you walk Jim Del Rosso through that case?
Yeah, that is a really interesting case. I'm getting chills because that's a really good case. This was a nice gentleman, Cuban gentleman. He looks white. He's not white, but he's Cuban. Came in with his daughter, and he works, and he says he does not leave his house. And he doesn't leave his house because he came in with this, probably I would say, the most dramatic rhinophyma I've ever seen. And I can only say that because now I do so many cases of them. He's by far I'll never forget his name ever. I mean, I will be 80 and I'll remember his name, and he's the nicest gentleman. And it was a difficult case because his rhinophyma was not just one large nose, he had a lot of fibrotic nodules. And, that is really hard. So he came in, and I was like, I got to do something. And so in the beginning,
How long did he have this rhinophyma?
years, like a decade.
Was he on any type of treatment that reflected trying to control his rosacea? Did he have inflammatory lesions of rosacea before
He,
that preceded it and you're just not seeing it now? Or
I mean,
what was
he
his
says
history?
really nothing, not an alcoholic, very otherwise, he had no history of inflammatory lesions, but really had swelling of the forehead. So he had, some rhinophyma or, some phymatous tissue up here, and then the nose.
Right. Well, the nose, rhinos for the nose, but you can get these hypertrophies in the chin,
Jen,
in the forehead. You can get phymatous changes. They don't always have to be rhinophymatous
hmm
changes. But was he purely on the nose at this point in time?
nose and forehead.
Okay. So, so he's one of those examples where he has rhinophyma. It falls and he has it on the forehead also.
Yep.
Um, diagnosed as rosacea without that typical inflammatory appearance, erythema, papules, pustules associated. So he's a pure phymatous change of rosacea.
hmm
So what did you do?
So I decided, the first step is we have to do this in stages. So the first appointment, we decided we were going to debulk the nose. So he came in, and I was removing all of these nodules. We removed all the nodules,
So is this under general anesthesia
local
or some type
anesthesia.
of Local
Yeah.
anesthesia. When I say general, do you give him something IV or IM to sedate him down, or all under local?
All under local, and then I will give them post-operative pain control. But if it depends on how he was ready, he was like, I want to go now. He was not like one of those people, very strong guy. Sometimes I give people preoperative Valium just to calm them down. He was already, at the position where this was his time to act. And so doing this procedure is extremely bloody. And so if your staff is not aware, and my staff was not aware what was going to happen, it can look like a murder scene, especially when you're doing the debulking. So the debulking, everyone does it a different way. I use, a 15 blade or 10 blade, and we're really just breaking down all that tissue down to the level of the sebaceous gland, because that's where you have to know. If you go beyond that, you're going to cause scarring, and that's not
Right.
what we want. So I debulk the nose at the first visit, and then after we debulk the nose,
So afterwards, he's debulked. What's the care that you're going to give? What's being applied?
so once the debulking is done, I lightly cauterize any vessels that I can see or any bleeding. I will do dry sol to, again, just to make sure hemostasis is under
Aluminum
control.
chloride. Aluminum chloride. Okay.
And then I will put gel foam on top. Okay, so gel foam acts as a nice hemostatic agent, barrier, wound repair agent, and it actually just soaks up some blood. So when we're putting that dressing on the nose, it actually makes it less, soupy.
So how often are you seeing him and follow up, and when will he be healed enough to go on to the next phase?
So it usually takes about 2 weeks for him to fully heal. And then I typically do the next phase, which is the resurfacing phase with the laser, probably 6 to 8 weeks after the original appointment.
Okay. All right.
And so 6 to 8 weeks later, we do the laser resurfacing. I'm really able to target the areas that I could not debulk, contour, texture, pores, really work around that nasal alar rim, working at the rim that, was causing some hypertrophy growing inwards and causing some breathing issues. And that was him after. That's probably 3 months after the resurfacing is the picture of that nose. And
So at that point in time, I mean, when they come back from the first phase, I would imagine, even though you have a sort of a denuded area that's not done yet, they have to feel pretty good about their noses looking tremendously different already. Correct?
Yes, and less heavy, easier to sleep. So yeah, you affect people on different levels with these types of treatments.
Right. So now the second phase, that's where you're becoming a little bit more of a sculpture like Michelangelo,
Exactly.
and you're getting the nose shape back. So now he comes back in and he's looking great, but what was there to drive it to form in the first place, you didn't take that away. So what's your management now?
So I typically do isotretinoin long term, and I have a couple of, and so it depends if the people can afford this procedure because it's not covered by insurance. Great. If not, then the next best step I typically do is I use a combination of neuromodulator with isotretinoin. So I will inject neuromodulator into the nose, into those nodules, into the sebaceous tissue to kind of give us a little bit of contraction of that tissue. And then we do isotretinoin as well to, again, help shrink that tissue over time. And it works extremely well. I have people usually on it for 2 years. The dosing is a little bit different than acne because I'm not going as high.
So let's go back. On this patient, you didn't do the neuromodulator, but
No.
that's a potential option other than doing the full ablative procedure. But in his case, you're talking about utilizing low dose oral isotretinoin?
Low dose oral isotretinoin. I'd probably do 20 milligrams
So every day or?
every day. Yep.
Okay.
And
Debate, you have to go through iPledge and get the laboratory testing. And what laboratory testing do you do in an older patient like this?
my biggest concern are the lipids in this situation because this patient was overweight. And so my concern was the triglycerides. So that was my biggest concern. I do order the basic labs, which for me, isotretinoin are liver function and lipid panel. That's it. I don't really check a
Right.
CBC or CMP.
Right, I agree.
And so that's where I usually monitor. He was not an alcoholic, so I wasn't worried. You have to catch things like fatty liver disease, which is by far extremely common nowadays. But for me, it's the triglycerides because we don't want to put someone in a potential situation that puts them at risk for pancreatitis or something like that.
something of that nature. And I remember many years ago with or chronic oral retinoid use, it was acitretin. John Koo did an evaluation thinking, we're using this chronically. Are we changing the lipids in a way that's going to increase their risk of having myocardial infarction or cerebral vascular accidents? And over, I believe, 5 years, they did not see any of those type of changes. So that's reassuring too in an older patient with isotretinoin, because they're going to be on this for years.
Yeah, I'm gonna guess 2 years, and maybe we'll take a break. And I think that's we're not even there yet, but that is my usual plan. It depends on the response. I think because we did the laser, I think we'll be in a good position. And then I told him in
So
2 years we might
so
resurface again.
So what you're doing now is that fully formed rhinophyma that he came in with fibrosis, the isotretinoin is not going to really change that. But when phymatous changes occur, it's a hyperplasia first
Yep,
that leads to a fibrosis. So you can certainly you can utilize low dose oral isotretinoin even intermittently for older patients that are just studded with sebaceous hyperplasia lesions, and they literally melt away and don't come back. So you're really preventing the recurrence of the rhinophyma, correct?
correct. Yep,
So, and he was very welcoming of that.
very welcoming. Easy. We had a plan from the get-go, and so once he saw the result, he wanted to maintain it.
So if he had told you, if he had gone online or a family member or even the patient themselves, like, I went online, I read about oral isotretinoin, I trust you, Dr. Lal, but it scares me. If he hadn't used the oral isotretinoin, would you have done something else or just left it to time? And then if it started coming back, then readdress it again?
I probably would say we need to do quarterly light resurfacing procedures with neuromodulator, because I
So
think that,
neuromodulated botulinum toxin you're
yeah,
talking about?
yep, because it does really shrink those glands very well, and I have some people that are happy with that response alone. So that's probably what I would have recommended.
But the neuromodulator doesn't come cheap. So if they couldn't afford the procedure, how are they able to afford the botulinum toxin?
Yeah, on a routine basis. Yeah. So those are the questions that come up. I mean, then I probably would have done. I would at that point it would be just sun protection, avoiding triggers, which for the most part he did. But usually with isotretinoin, when I tell them that I take low dose isotretinoin, it kind of helps the conversation.
No, I can tell you right now, low dose isotretinoin helps this Italian rubber nose, which is sebaceous hyperplasia, to not become probably not like your patient, but certainly on its way. So
Yeah.
I think these are practical discussions that people might not think about or know that they're available. So to me, these were three fascinating cases that not quite go like Star Trek, where no man has gone before, but certainly you looking at the patient and saying, how can I help them? And doing things that are not always necessarily conventional. So I appreciate that, and I appreciate you sharing that information. But I'm not letting you off the hook yet.
Okay.
Okay. Yeah. So you and I have fascination with fashion, clothes and shoes, and we've talked about it. So in Karan's treks in different locations when you're traveling, you do some shopping.
hmm
What is the last purchase you have made for a pair of shoes?
I'm glad my mom won't watch this, but the last purchase was about 2 weeks ago, and I was online, and denim and camo are both in right now, and so I saw these denim sneakers, and I was like, I have a lot of conferences coming up in the fall, and I have some blue outfits that I think I could work. I want to get something to wear, and so I saw these pair of Christian Louboutin. These they're called Astro Lubies, and they're denim, and they have spikes on the back. And so that was my last purchase.
Astro Lubies,
Yep.
right? I'm going to have to check that out. There is a Christian Louboutin store over in Vegas, so
Yeah.
maybe you can bring me over there, and
Let's
maybe
do
I'll
it.
pick up a pair. But But it's great talking to you. I appreciate you sharing your knowledge. Just to let you know, Dr. Lal has also worked with Derm Squared on his Instagram channel. So we do tea. We like pouring tea with people and having conversations. He does skin tea, and he is presenting, and I know he's presented some. I think he has a couple more or coming up if they're not finished yet. 3 programs on GLP-1 use, a series to give education on how to integrate GLP-1 therapies and reducing weight for different disease states like psoriasis and even hidradenitis suppurativa.
Hmm.
So if you see Dr. Lal anywhere, you see something posted, I suggest you look at it, because it's not going to be just the same story over and over again. He's always going to take you one step further, at least one step. So thanks a lot for being here today. My second Tea with Dr. D episode, and I couldn't think of a better guest. Thanks a
Well,
lot.
thank you for having me.